the first and the third story that I'm talking about are heavily de-identified. This isn't heavily de-identified. The patient has given me permission to talk about him. And the reason, the particular reason is that his occupation is very important for the story. Eric was a firefighter, was a real firefighter. He was diagnosed with PTSD. He'd been referred to me after a series of other treatments. I saw him in a conversational type of therapy. He talked to me about a car accident that he had attended in which a young woman had been killed by an intoxicated driver. He was very angry about that. He said that he felt as a result of that he froze later on in a house during a fire. He was anxious and avoidant, as patients with adult PTSD are, and he'd been admitted several times with thoughts of self-harm, and he wasn't functioning at all. He had wife, children, really couldn't hold down any sort of a job. He'd had a number of antidepressants and he'd had 2 trials of CBT. He started to talk to me about his father and that he grew up in his father's wrath. He said that his father was always yelling at him and belittling him, and that made him feel small and unworthy. He said, "You never live up to his expectations." We grew up in absolute silence and everything was done Dad's way. He and his brother were never allowed to make any noise. They couldn't run about the house. I think all the furniture was covered in plastic as well. He soon came to the conclusion in therapy that every time he had a conversation with anybody, he was expecting the wrath of his father, and that he never offered opinion of his own. He thought people could see through him, and his greatest fear was of being found out, of being a fraud, of making mistakes, and this is really why I left his job, why I couldn't hold down any other jobs. He eventually realised he expected his new therapist to tell him how to get better, just like his previous therapist and his father would have done. And when this didn't happen, he realised that he could take part in his own therapy, that he was worthy of existing in his own right and in relation to another. And this can only happen with an awareness of what happens in between. He slowly grew in confidence twice weekly for 3 years, within and then outside of the therapy, and he eventually retrained and got a job. After 3 years, his therapy was terminated, and I'd never looked at a single symptom. The much earlier traumas of invalidation by his father were much more significant than the post-traumatic stress disorder, the anxiety or the depression. Structured therapy had failed because it had failed to consider what had happened between the patient and the therapist, and medication hadn't addressed anything in particular. So I'm going to talk now a little bit about how we got to not looking at symptoms through the history of psychiatry, and this section will be a little bit brief. My view of psychiatry is that it is subject to fads and trends and paradigm shifts that aren't particularly evidence-based, and more so than other branches of medicine. Sometimes the same patient can be offered treatments that look almost polar opposites. Understanding how we got to be here, I think, is really important. Psychiatry is something like, well, we can date it for 2,000 years, but really we've only been looking at it for a couple of 100 years. 200 years ago, when people were in asylums, everything was primarily custodial. People were sometimes bolted to the floor. There was a wave of optimism in the middle 19th century, but for various reasons, asylums were overwhelmed with numbers of patients around the turn of the 19th century, and any attempts at more humane care were swamped. This is a famous painting called Rakes Progress, painted by an Englishman in the early 18th century. It's one of a series of 8. And the reason that I've got this here is for the background. There are musicians and there are women dressed with fans. They're there for a social event. Shorter wrote in his History of Psychiatry that people used to go to Bethlehem to stare at the lunatics. For a penny one could peer into the cells, view the freaks and laugh at their antics, generally of a sexual nature or of violent fights. Entry was free every 4th Tuesday. Visitors were permitted to bring long sticks with which to poke and enrage the inmates, and there were nearly 100,000 visits in 1814. Things did happen in the 19th century though in psychiatry. Classification really began with Kraepelin, who divided everything into the two major psychoses in the 1890s, and that's still the basis of the DSM. Now, around about this time, if you read Ellenberger's History of the Unconscious, which is about 1 million pages thick, he talks about there have been two groups of psychiatrists, and I think there still are, the somatica, who generally attributed mental disorder to brain disease, or the biological psychiatrist, and the psychica, or the analyst. And the analyst held sway until about 50 years ago. There were, however, many, many brilliant people working around the end of the 19th century who understood trauma and personality. We've heard this before, and I won't go into it in any depth. I've mentioned Freud yesterday. He's been mentioned 3 times. He did a lot of good things, but he did some bad things. Louise talked about that as well. Retracted his theory about incest being causative in 1896 after publishing it in 1897 after publishing it in 1896. And Judith Herman, who wrote Trauma and Recovery, in which he coined the term complex PTSD, has been heavily critical of Freud, stating that the psychological study of trauma came to a halt in 1897, so that's 114 years ago. There were a number of paradigm shifts that were very important though in the middle of the 20th century. Largactil or chlorpromazine was discovered in 1852, implemented in 1954, the beginning of the deinstitutionalisation. That did 2 things. It got people out of hospitals, but it also started people looking into neuroscience and receptors, which is why we've got so many medications now. So sort of along parallel lines, the women's movement, Vietnam vet studies in the 1970s began the study of trauma. Studies of trauma were very much promoted by the publication of the DSM-3 in 1980, which talked about PTSD and borderline personality disorder, but did a funny thing. It said PTSD has a cause and borderline personality doesn't, which was rather unhelpful, and that's 31 years ago. The DSM classification system started in the 50s. We're due for DSM-5 in about 2013. It's very unfortunate. They were thinking about collapsing Axis 2 into Axis 1, which would have meant that the trauma-related conditions like borderline personality disorder were seen as bona fide conditions. They're not doing that anymore. But the DSM-3 in 1980 was published as in reaction to analysis. Analysts saw people holistically, and they listened to their problems, and they weren't interested in symptoms, but they didn't categorise very well. So the DSM-3 was written for researchers to try and lump people together more accurately so that we could better understand things. It is a research document that's been bastardised into a diagnosing document. DSM-4TR has 300 diagnostic categories. Multiple diagnoses or comorbidity are the norm. We've heard about this before. Now people are talking about DSM not doing what we do in the rest of medicine. If you have pokey eyes, a tremor, heat intolerance, diarrhea, you don't have 4 different medical problems, you've got thyrotoxicosis. If you've got 4 different symptoms, in psychiatry you normally get 4 different diagnoses. DSM doesn't cut nature at its joints. It doesn't follow medicine's routine use of a thing called Occam's razor, or the theory of parsimony, which states that entities should not be multiplied beyond necessity. Oops. So the edifice of DSM is slowly falling. Gordon Parker, an Australian affective disorder researcher, has been very critical. He's followed a non-clinical group of people and found that almost all of them are diagnosable with some sort of condition. You can now be diagnosed with bipolar disorder without ever having had an episode of mania. Lots of criticism about bipolar disorder, all sorts of other things, pretty much in the realm that Louise was talking about this morning, the sorts of things in the child arena that are trauma-related, that are given other diagnoses. So DSM is being increasingly criticised for being reductionistic, with an overemphasis on the biological, for over-medicalising and oversimplifying the human condition, and for pharmaceutical company conflicts of interest for panel experts. I could go into that in great more detail, but I won't. And in the US, we know it's called the Bible of Psychiatry. It runs everything, whether you go to prison, whether you don't, whether you get funding. I think in 2009, Linford and Arden published an article where they have described this as the Pax Medica. This is a combination of DSM, Prozac, which means Big Pharma or the drug companies, and the rise of the evidence-based therapies. And this Pax Medica is one paradigm that seemed to be erroneously founded on theories of chemical imbalance in the brain, with an inappropriate emphasis on symptom-based diagnoses and on specialised techniques and treatments. They say this has medicalised psychology and psychiatry in a way that has become so pervasive it's almost invisible, like the air we breathe. In a book that's becoming, I think, more influential, The Loss of Sadness, written by two sociologists, they argue that while depressive disorder exists and can be a devastating condition, the apparent epidemic of depression reflects the way that the psychiatric profession has reclassified normal human sadness as largely an abnormal experience, as a diagnosis of depression fails to take into account any personal context. And the foreword was written by the architect of DSM-3, Robert Spitzer, who admits it's a devastating critique of the classification system. Snoopy says it best. Back to the left and the right hemisphere. The DSM was designed as a communication and a research document to more accurately categorise syndromes. Very unlike most of medicine, less rarely, but not always, less rarely does the diagnosis assist with the treatment planning and prognosis, as there is much less etiology pathogenesis. No, obviously that doesn't apply to conditions like frontotemporal dementia. The focus on delineating Axis 1 conditions, symptom-based clusters, in my opinion, mirrors McGilchrist's left hemisphere concern about an overly narrow, scientific, mechanistic and fragmented focus at the expense of a more holistic, emotional and social perspective. It wasn't designed to do that. There are 5 axes and you're supposed to include them all, and if you use it correctly, it's fine, but you have to have your right hemisphere switched on to put it into context.